Welcome to the Radiographics Podcast. I'm Wendy Gibbs. This week, we've got two more interesting articles from the most recent regular issue of the journal. I'll be summarizing an article about a fascinating in a bad way, pathologic process which affects all systems of the body, but affects each system in a unique way: amyloidosis. I'll also give you an update on the growing importance of imaging in diagnosis, monitoring treatment, and drug development in the most common amyloid-related pathology, Alzheimer's disease. On the other end of the spectrum, my co-host Ross Frederick reviews a RADPath paper by the AFIP or AIRP greats on a small but critically important structure that, when dysfunctional, can also affect the whole body: the pituitary gland. Let's start with amyloidosis. Amyloidosis, multi-system spectrum of disease with pathologic correlation. Amyloidosis is a group of conditions defined by extracellular deposition of insoluble proteins that can lead to multi-organ dysfunction and failure. The systemic form of the disease is often associated with plasma cell dyscrasia, such as multiple myeloma, but may also occur in the setting of chronic inflammation, long-term dialysis, malignancy, or multiple hereditary conditions. Localized forms of the disease most often involve the skin, tracheobronchial tree, and urinary tract, and typically require tissue sampling for diagnosis, as they may mimic many conditions, including malignancy, on imaging alone. Advances in MRI and nuclear medicine have provided greater specificity for the diagnosis of amyloid-related pathology involving the central nervous system and the heart, potentially obviating the need for biopsy of the affected organ in certain circumstances. For instance, a combination of characteristic findings at non-invasive cardiac MRI and skeletal scintigraphy in patients without an underlying plasma cell dyscrasia is diagnostic for cardiac transthyretin amyloidosis. The imaging features of amyloid vary across each organ system but share some common patterns, such as soft tissue infiltration and calcification, that may suggest the diagnosis in the appropriate clinical context. The availability of novel therapeutics that target amyloid protein fibrils, such as transthyretin and the new Alzheimer's drugs, highlights the importance of early diagnosis. Amyloidosis is broadly categorized as systemic or localized and as hereditary or acquired. The nomenclature of describing amyloidosis is based on the fibril type, with the former terms primary amyloidosis, now called amyloid light chain, AL, and secondary amyloidosis, now referred to as amyloid A, or AA amyloidosis. The most common form of systemic amyloidosis in the United States is amyloid light chain, which is associated with an underlying plasma cell dyscrasia and is characterized by abnormal deposition of protein fibrils derived from immunoglobulin light chain fragments. As an aside, if you don't remember or exactly know what a plasma cell dyscrasia is, I had to look this up. This is a group of diseases characterized by expansion of monoclonal bone marrow plasma cells that produce monoclonal immunoglobulins. So examples are multiple myeloma and MGUS. Nearly all of these patients with primary amyloidosis or amyloid light chain will have a detectable monoclonal light chain in the urine or serum, and a fraction of them, about 20%, will have concurrent multiple myeloma. AA amyloidosis is caused by fibril formation derived from an acute phase precursor protein produced in the liver, serum AA. So AA amyloidosis is associated with chronic infection or inflammation, solid organ malignancy, and familial conditions such as familial Mediterranean fever. I didn't know that. Multisystem manifestations are common in both AL and AA amyloidosis, often manifesting clinically with heart failure with preserved ejection fraction, nephrotic range proteinuria, or peripheral neuropathy. There are several other clinically relevant types of amyloid. Transthyretin amyloidosis, or ATTR, is a significant cause of morbidity and mortality related to cardiomyopathy. Amyloid deposits can also be found and associated with certain malignancies at pathologic analysis, including medullary thyroid carcinoma, renal cell carcinoma, and extranodal marginal zone lymphoma, or MALT lymphoma. The goal of therapy is to reduce quantity or bioavailability of precursor proteins to amyloid fibrils, but this may not lead to regression of existing deposits. Targets for therapy depend on the extent of organ involvement and comorbidities, including associated inflammatory conditions such as rheumatoid arthritis, predisposing malignancies such as non-Hodgkin's lymphoma or multiple myeloma. For patients with AL amyloidosis, high-dose intravenous melphalan, an alkylating chemotherapy agent, and autologous stem cell transplant may be considered in eligible patients. Other novel therapeutics aim to stabilize specific precursor proteins and prevent dissociation into monomers, such as tafamidis for the treatment of ATTR cardiomyopathy. Let's talk about multisystem imaging in terms of the central nervous system. Diseases of the central nervous system related to beta amyloid peptide deposits include Alzheimer's disease, cerebral amyloid angiopathy, amyloid angiopathy-related inflammation, and amyloid beta-related angiitis. Beta amyloid is a proteolytic cleavage product of amyloid precursor protein, APP, a transmembrane protein that is expressed in the neuronal synapses. Alzheimer's disease is the most common cause of dementia and is associated with characteristic neuropathologic changes, including extracellular beta amyloid deposition, which is the neuritic plaques, and intracellular accumulation of hyperphosphorylated tau protein, that's your neurofibrillary tangles. Evaluation of patients with suspected Alzheimer's disease starts with MRI, which is mainly performed to exclude alternative causes of mild cognitive impairment or dementia, particularly in early stages, and to quantify volume loss. As Alzheimer's disease progresses, structural changes may become apparent on CT and MRI, including atrophy of the entorhinal cortex, hippocampus, and precuneus. Several molecular imaging PET biomarkers are available for assessment of cerebral amyloid deposition and diagnostic evaluation for dementia. Two of these PET biomarkers have complementary roles. So FLOR-beta PET, which binds preferentially to beta amyloid fibrils, and FDG PET, which we all know, which acts as a glucose analog to assess metabolism. Using amyloid PET, the presence of amyloid is indicated by abnormal tracer uptake in the cortical gray matter. So a negative amyloid PET means there's some other reason for your memory loss. FDG PET in Alzheimer's disease characteristically shows hypometabolism in the posterior cingulate cortex, precuneus, and parietotemporal cortices. Hypometabolism is a less specific finding. I have a great picture of activity on amyloid PET exactly corresponding to the hypometabolism on FDG PET, showing how the amyloid has killed those cells. I'll put that on Twitter for you all. As an aside here, I want to give you an update on Alzheimer's treatment and the importance of imaging, both MRI and PET, in diagnosis, selection of patients for treatment with the new drugs, treatment monitoring, including for side effects, and testing of the new pharmaceuticals aimed at reducing amyloid burden. In June, the FDA gave marketing approval to Biogen for Aduhelm, an antibody that aims to reduce amyloid plaques in the brain. This has been controversial as experts are divided on the efficacy of this drug, and this treatment is not without risks. But it shows the importance of imaging in the treatment of this widespread, devastating disease, as MRI and PET are required for all the steps described above. ARIA, or amyloid-related imaging abnormalities associated with the new treatments, includes brain edema and hemorrhage. And it's important for radiologists to know if a patient with these findings are on this drug, as imaging is the only way to know what's wrong with them when they present with headache, altered mental status, and focal neurologic deficits. Many of these older patients will go to an ER when this happens, and not necessarily the one where they're getting their treatment. More to come on all this in upcoming radiographics issues. Another pathology that affects the brain is cerebral amyloid angiopathy, an important cause of primary intracerebral hemorrhage in older patients. It may manifest sporadically in association with Alzheimer's disease or rarely in a hereditary form. The disease is characterized by deposition of beta amyloid in the media and adventitia of small arteries within the brain and leptomeninges. And this is why you see hemosiderin deposition peripherally in the brain on your MRI susceptibility weighted image, which helps differentiate it from hypertensive-related microhemorrhages, which are centrally located in the basal ganglia. The modified Boston criteria uses imaging findings to evaluate the probability of having amyloid angiopathy. Features to describe include multiple intracerebral hemorrhages or cerebral microbleeds restricted to lobar, cortical, or cortical subcortical regions, or alternatively a single hemorrhage or microbleed in these regions in the presence of cortical superficial siderosis. I have another great picture of this that I just got. I'll also post that on Twitter. This applies to patients 55 years or older in the modified Boston criteria, and this may be new to many practicing radiologists who are probably taught that you shouldn't consider amyloid angiopathy in anyone below the age of 70. What about inflammatory amyloid angiopathy? This is an inflammatory response to the beta amyloid deposition in the vessels. Cerebral amyloid angiopathy-related inflammation and amyloid beta-related angiitis are usually seen in patients 70 or older, so the older patients, with symptoms of cognitive decline, headache, seizures, and focal neurologic deficits. In addition to multiple cortical microbleeds, you also see infiltrative or tumefactive white matter lesions and patchy leptomeningeal or parenchymal enhancement, and this helps distinguish this disease process from the typical amyloid angiopathy without inflammation. Okay, that stuff's fascinating. I could talk about it all day, but let's move to cardiothoracic manifestations. Amyloidosis involving the heart manifests as restrictive cardiomyopathy due to infiltrative amyloid deposition in the myocardial interstitium, resulting in expansion of the extracellular space and biventricular myocardial thickening, often with preserved ejection fraction. The most clinically relevant types of amyloid in cardiac disease are AL and ATTR, which is further subdivided into senile or wild type and hereditary or mutant type forms. Recent developments have brought about renewed interest in cardiac amyloidosis, including imaging-based non-invasive diagnostic techniques, approved novel therapies, and recognition that this condition remains underdiagnosed. Early diagnosis of cardiac amyloidosis is key, as the natural history of the disease is gradual progression and death within 6 months to several years following diagnosis. In addition to echocardiography, non-invasive diagnosis includes cardiac MRI and skeletal scintigraphy. Cardiac MRI has a dual purpose in evaluating for features associated with amyloid and excluding alternate causes of heart failure. Typical MRI findings in cardiac amyloidosis include global subendocardial or transmural late gadolinium enhancement, elevated native T1 myocardial signal and extracellular volume, and absence of residual blood pool contrast material on delayed post-contrast images. When cardiac MRI suggests amyloidosis, evaluation for a monoclonal protein and with skeletal scintigraphy is used for differentiating ATTR from AL amyloidosis. Skeletal scintigraphy in cardiac amyloidosis is performed with radiotracers such as technetium-99m pyrophosphate and technetium-DPD, which bind to microcalcifications within the amyloid matrix. Differentiating these has important implications for therapy, and you can make a diagnosis without need for tissue biopsy. Well, that's all we have time for right now, but this article has much more information about amyloid deposition in just about every body system. And the path pictures are amazing, so take a look at the article online or in the print journal. Let's move from this group of diseases that affect the whole body to the diseases of one small but very important body part, the pituitary gland.
Primary tumors of the pituitary gland. Radiologic pathologic correlation. Tumors of the pituitary gland are the second most common primary tumors of the central nervous system, after meningiomas. The pituitary gland consists of an anterior portion, the adenohypophysis, and a posterior portion, the neurohypophysis. The anterior pituitary is not formed from neuroectoderm, but by a diverticulum of oral ectoderm from the primitive mouth or stomotium. This outpouching is known as the Rathke pouch or craniopharyngeal duct because of its course from the oral cavity to the pharynx through the sphenoid body into the cranial vault. The posterior pituitary is derived from the central nervous system, hence the neuro and neurohypophysis, and has direct axonal projections from the hypothalamus through the infundibulum. This article divides primary pituitary tumors into 3 sections from most to least common. The common primary tumors of the adenohypophysis, the uncommon primary tumors of the Rathke pouch, which are embryonic precursors of the adenohypophysis, and the rare primary tumors of the neurohypophysis. Let's begin with primary tumors of the anterior pituitary, most of which are pituitary adenomas. Pituitary adenomas are monoclonal tumors that are usually incidental without clinical significance. Pituitary adenomas smaller than 10 millimeters are microadenomas, while those 10 millimeters or larger are macroadenomas. The term giant pituitary adenoma has been used to describe tumors over 4 centimeters. Pituitary adenomas that secrete excess hormones are considered functional adenomas and account for 2/3 of clinically evident adenomas. As a general rule, women tend to present with symptoms earlier in life, often being diagnosed with a prolactin-secreting adenoma, while men tend to present with symptoms later in life, often being diagnosed with a non-functional or non-secretory macroadenoma. Macroadenomas can result in headache and visual field deficits related to local mass effect and extension into the suprasellar region with optic chiasm or optic nerve compression. Lateral cavernous sinus invasion can cause palsies of cranial nerve 3, 4, or 6. Compression of the pituitary gland or infundibulum may cause hypopituitarism. The management of pituitary adenomas depends on their subtype. For example, prolactin-secreting adenomas are highly responsive to dopamine agonist therapy, whereas growth hormone-secreting adenomas are treated surgically. MRI is the modality of choice for evaluation of the pituitary and paracellular region. Pituitary adenomas typically show delayed enhancement and washout relative to that of a normal gland on post-contrast images. An additional dynamic post-contrast sequence can sometimes be helpful for accentuating differential enhancement and delineating tumor, such as in the setting of clinically suspected microadenoma. When evaluating a cystic cellular mass, T2-weighted imaging features such as a fluid level, hypointense rim, septation, and off-midline location are more commonly associated with pituitary adenomas. In addition to an expanded pituitary contour, macroadenomas can show displacement of the infundibulum and suprasellar extension, with optic chiasm or nerve compression, cavernous sinus invasion, and erosion of the sellar margin. Cavernous sinus invasion is predicted based on the NOSP system, which is based on tumor extension relative to the cavernous internal carotid arteries. Head CT is usually the initial imaging modality of choice for acute onset neurologic symptoms, including the characteristic visual loss in the form of bitemporal hemianopsia, which is seen in pituitary apoplexy, and is able to quickly help confirm the presence of an intracellular or suprasellar mass compressing the optic chiasm. While CT hyperattenuation may be evident in the first few hours, MRI is superior for determining initial T1 isointensity and T2 hypointensity, followed by subsequent T1 and T2 hyperintensity, often with a fluid level, reflecting evolution of intratumoral blood products. Surgery remains the primary method of treatment, although an increasing number may be managed conservatively. Let's discuss the uncommon primary lesions of the Rathke pouch, which includes Rathke cleft cyst and craniopharyngioma. During development, if the Rathke pouch fails to obliterate, a cystic remnant may persist in the cleft between the pars distalis and pars intermedia, producing a non-neoplastic Rathke's cleft cyst in the sellar or suprasellar region at the anterior margin of the neurohypophysis or infundibulum. The cyst can have variable T1 and T2 signal intensities, with the majority having T1 iso or hyperintense signal. An intracystic nodule may be found in 3/4 of lesions, typically exhibiting T1 hyperintense and T2 hypointense signal relative to that of white matter, although variable low T1 signal intensity has been described. Solid or nodular enhancement does not occur in Rathke's cleft cysts, although thin peripheral enhancement may result from compression of normal adjacent pituitary tissue or inflammation of the wall. The second tumor of the Rathke pouch is the craniopharyngioma. The more common subtype, the adamantinomatous craniopharyngioma, comprises 90% of lesions. It has a bimodal age distribution and affects both children and adults between the ages of 40 and 60. They can arise anywhere along the embryologic path of the Rathke pouch, from the craniopharyngeal canal within the sphenoid body to the intracellular pars distalis and suprasellar pars tuberalis. On imaging, adamantinomatous craniopharyngiomas are usually cystic or predominantly cystic and located above the sella, although roughly 1/4 will be both intracellular and suprasellar. Cystic components can show variable signal intensity on T1 and T2 weighted sequences, depending on protein content, and solid components show avid enhancement. At CT, the adenomatous subtype will often show associated calcification, especially in pediatric patients. The less common subtype of craniopharyngioma is the papillary craniopharyngioma, which occurs exclusively in adults. The papillary subtype rarely calcifies and tends to have a greater solid component than the adamantinomatous subtype. Treatment of craniopharyngioma may consist of a gross total or subtotal resection, plus or minus radiation therapy. Postoperative quality of life needs to be weighed in light of the significant consequences of treatment-related hypothalamic damage. Cystic decompression and installation of sclerosing agents is a possible alternative. Let's move on to our third and final section of pituitary tumors, the rare primary tumors of the neurohypophysis. These are pituocyte-derived tumors and include pituocytomas, granular cell tumors, and spindle cell oncocytomas. All of these entities can manifest on imaging with solid enhancing intracellular or supracellular masses and also have similar clinical manifestations. If the solid enhancing mass is small enough to be clearly identified as arising from the neurohypophysis or infundibulum and not the adenohypophysis, then pituocytoma belongs in the differential diagnosis. Granular cell tumor is part of the differential if the mass is supracellular arising from the infundibulum. Spindle cell oncocytomas are characterized by aggressive infiltrative growth and usually manifest as a large intracellular or supracellular mass, and therefore are easily mistaken for a non-functional pituitary macroadenoma. Alright, recap time. Primary tumors of the pituitary gland can be subcategorized as common primary tumors of the adenohypophysis, which includes pituitary adenomas, uncommon primary lesions of the Rathke pouch, which includes Rathke cleft cysts and craniopharyngiomas, and rare primary tumors of the neurohypophysis. Common things being common, most of the time the diagnosis of an intracellular or supracellular mass will be a pituitary adenoma, and either medical or surgical therapy may be offered, depending on the functional status and size of the tumor. Remember that the neuroimaging appearance of cystic macroadenomas can overlap with that of Rathke cleft cysts and adamantinomatous craniopharyngiomas.
Wow, very nice. And anyone who reads a head CT for any reason, whether you're ER, general radiology, in training, watch that pituitary gland. You might not be able to see what's going on CT, but you can often tell something's not right and get them to MRI. Great RadPath pictures with this one as well, so take a look at this paper. All right, we're out of time for this week. Join us again in 2 weeks for more summaries.